we do this through a number of different goals. We are a $1 billion a year annual organization. And we fund typically around $150 to $170 million in new research, much of it focused on those innovative young people who are just starting out and testing their important new ideas in science. But a lot of it also focused on improving the public health and the community health of many of our populations, both in the United States and around the world. In fact, the American Heart Association is the #1 funder of cardiovascular brain science outside of the US federal government, and we're really proud of that. But we also are in communities, in schools, working with community leaders, trying to improve not just healthcare access and quality of health, but also actually directly trying to improve the social determinants of health, those upstream factors that are the causes of heart disease and stroke. Things like education that Dr. Yusuf just talked about, so important. Things like socioeconomic position, access to healthcare, access to healthy foods, the ability to perform physical activity in safe spaces. All of these things, the places where we work, we're born, we live, we eat, we play, and we pray, all of these things are critically important, and we must address them if we truly are going to create a world of longer, healthier lives. And finally, AHA also is intensely active in advocacy efforts, working at the international, the federal, the state, and at local levels to try to improve all of the things that actually affect our health and our lives. So I want to start, as I said, kind of digging in on what we call a scientific statement, which is actually a roadmap created by AHA scientific volunteers to help both the AHA staff and the AHA organization organize our thoughts about how we should address cardiovascular disease and cardiovascular health, in this case in South Asian communities. But this also provides, I think, a roadmap for researchers, for community leaders, for lay individuals to understand the current state of science in our understanding of South Asian cardiovascular health, and also where we need to go to improve that health. I'm so pleased to recognize Annabelle Boltman, who chaired this wonderful committee of volunteers, and of course the Vice Chair was Lania, who's joining you as a speaker there, and has been a great AHA volunteer for a long, long time, addressing many of the issues that are pointed out in this document. So one of the things the document does is to talk about what is the experience of the South Asian American population in the United States, many of whom are migrants, many of whom are first-generation American-born individuals, and some now second-generation as well. This is the distribution of South Asian Americans in the United States. As you can see, largely focused in urban areas, where you see the darker kind of blotches on this map. And that obviously drives some of the health issues that can happen in those communities. But Dr. Yusuf just covered many of these things very interestingly. You know, we do see that when we can disaggregate from among all Asians, we can disaggregate Asian, Indian, and South Asian groups, we do see continued higher proportional mortality ratios for both all cardiovascular disease, excuse me, here on the left, for both women and men. Asian Indians have the highest rates of proportional mortality for cardiovascular disease, and even less focused on, we talk about coronary heart disease a lot, but even higher proportional mortality ratios for cerebrovascular disease as well. Anything above 1 means disproportionate burden in that group compared to non-Hispanic whites. So this conference is all about many of these things, so I'm not going to spend too much time, excuse me, diving into this. But the document goes through many of the biological and non-biological mechanisms that appear to contribute to the excess risk of fatal and non-fatal atherosclerotic cardiovascular disease in South Asian individuals. And as Dr. Yusuf points out, and I think it's very important to note, that the onset of coronary heart disease in particular tends to occur about 10 years younger, especially in men, but also in women of South Asian heritage. And so, you know, there are more life years lost in this population because of that earlier onset of coronary heart disease, and more quality life years lost as well. So very important to focus on what is driving some of this excess risk of atherosclerotic cardiovascular disease. Much of the work done by Dr. Yusuf's group has shown us through the InterHeart study and many other studies that the traditional cardiovascular risk factors, as he outlined, appear to account for, obviously, the vast majority of risk, but each of those appears to account for similar population attributable fractions in South Asians compared to other populations, but there may be higher prevalence of certain types of those risk factors. And again, much of the conference is focusing on this observed higher rates of insulin resistance, of metabolic syndrome, and of type 2 diabetes, where we see the largest disparities in prevalence compared with perhaps more majority populations in this country. Twofold higher prevalences of diabetes and impaired glucose tolerance compared with non-Hispanic whites, and of course that underlying higher fasting insulin levels and greater insulin resistance driving those features. Obesity and adiposity, of course, an interesting problem because if we define the world by the cut points we use in Northern European white populations, we wouldn't call obesity until a BMI of 30 kilograms per meter square. But of course, what we see in South Asian and other Asian populations is that at a lower BMI, we see more metabolic problems, and we see more visceral and ectopic fat occurring in South Asian individuals than we see in, for example, the comparative group of non-Hispanic whites. So we need to understand the WHO thresholds, which I think make a lot of sense, for implementing lower BMI thresholds to consider someone at cardiometabolic risk if they're from South Asian heritage or other Asian communities as well. Now, dyslipidemia, you're very familiar with this, tending to have higher triglycerides, lower HDL cholesterol, higher ApoB indicating higher particle numbers of LDL and the other atherogenic particles, and some interesting data around higher cholesterol esterase transfer protein activity among individuals of South Asian heritage as well. All of these things, together with the very well described higher prevalence of elevated lipoprotein(a), tending to push towards a more atherogenic and, as we'll talk about, more thrombogenic milieu. Hypertension, there are issues about control rates among immigrant populations. So in South Asian communities in this country, because sometimes there are issues of access to care and of course of awareness and treatment, let alone control, these can be issues around hypertension as well. Because of the higher cardiometabolic risks related to diabetes and hypertension, as we just talked about, chronic kidney disease, I think, is an unappreciated epidemic among our South Asian communities as well and needs further attention, no doubt about it. I mentioned the inflammation and thrombophilia, which come with much of that sort of metabolic syndrome and multifactorial causes, but that drives, obviously, earlier event rates as well. And then there's a very nice discussion in the paper about what are the potential genetic factors that could be driving some of this excess risk, and a nice discussion of thrifty genes that if evolution has raised us in a situation where famine is common, we tend to drive a genetic underpinning that will be primed to store calories when they're available to us. And that can then lead to some of these problems of overstorage of fat in depots that are more metabolically active and less healthy. Drifty genes, sometimes there is some chance within populations. And then the sort of obverse of all this is that populations that migrated to colder climates to, let's say, Northern Europe, may have selected genes that were more favorable then in terms of metabolism, and there was not that pressure on the gene pool, perhaps in individuals and populations that stayed in South Asia. So some interesting discussion of that. There are, it appears, some novel associations of certain genotypes that are specific to individuals of South Asian heritage that are, I think, of research interest and developing. And we certainly need to do a lot more work here. If you look at the big studies like the UK Biobank, where we have whole genome sequencing in, tens of thousands, hundreds of thousands of individuals, there's underrepresentation of individuals from South Asian heritage. So we really need to beef up our capacity to understand, again, to obtain whole genome sequencing and then understand some of the low frequency variants that can actually drive risk in different populations. But of course, beyond biology, there are a lot of non-biological mechanisms that contribute to the excess risk of atherosclerotic disease and the earlier onsets in South Asian individuals. And many of these do have to do with those social determinants of health that we've been talking about. Again, because South Asian immigration to the United States has been a more recent phenomenon than perhaps for other groups, there are issues that are sort of competing here. There's a healthy migrant effect. People who migrate tend to be younger on average and tend to be healthier on average because they're the folks who can actually leave their home and take the risk of going to a new country. But once arriving, there are issues of assimilation that can affect access to healthcare for good and bad. And then of course, there are issues of assimilation that drive worse health factors, such as we know that longer duration of residency in the United States and greater acculturation towards the majority culture is associated with worse risk factor profiles. The westernization of people's diets doesn't necessarily do them any favors in many cases. And as Dr. Yusuf pointed out, the increasing intake of processed foods, which have a lot of unhealthy things in them, actually can drive those worsening risk factor profiles. So while, as he discussed, the South Asian diet is higher in carbs and low in meats, fruits, and vegetables, that can be exacerbated sometimes by the type of diets that people are exposed to here in the United States. And we really need to know a lot more about how to optimize the experience and the transition of the diet to make sure it's a more healthy transition. In general, people in South Asian communities participate in lower physical activity amounts on average compared to other groups in the population. There are some very interesting issues around culturally specific tobacco products. While traditional combustible cigarettes use is quite low in South Asian women in this country, it's about average compared to the rest of the population for South Asian men, but there are other tobacco products, hookah and so forth, that I think are of interest and we need further understanding about how to both reduce the use of those products and also what the long-term health effects may be. And then, of course, much focus on psychosocial factors, again, particularly related to immigrants and first-generation individuals and those important social determinants of health. You've heard me say it a lot of times because they are so critically important. Now, some of the discussion here at the conference has talked about the fact that we don't have great risk assessment tools for individuals of South Asian heritage. The cohort equations used in the ACC-AHA guidelines, even the equations such as Q-risk2 and the equations used in the European guidelines tend all to underestimate the risk for individuals of South Asian heritage. And so there are certain fixes that the guidelines put in, counting South Asian background as a risk-enhancing factor in the US guidelines, some risk multipliers that are used, multiply the calculated risk by 1.4 for South Asian men in the UK, no guidance given for South Asian women. We just need more data to either develop new short-term and long-term risk equations for individuals from South Asian communities, or we need to study a little bit more how to fudge the risk equations that we use for others. Of course, we need culturally tailored lifestyle interventions. Here at Northwestern, my wonderful colleague, Dr. Nami Kandula, is doing some wonderful work in South Asian communities, particularly with South Asian women, to tailor lifestyle interventions so that they're more acceptable and they're more actually, they're more able to adhere to those recommendations. We need to know more about the efficacy of some drugs and the safety in South Asian populations. A commonly cited one is this CYP2C19 variants in South Asian populations, more common, which can lead to differential metabolism of rosuvastatin, and there are certainly recommendations about starting with lower doses with that particular drug. And then, of course, again, tailored community prevention and health promotion strategies, so important. So these are the future directions outlined in that document. I hope I've whetted your appetite to go read it. It was in circulation in May of 2018, and I think there's a lot of work for us to do to improve the health, again, of our South Asian community. So now I want to talk just for a few minutes about our 2024 impact goal. You may know every decade the American Heart Association sets out a bold strategic impact goal to improve the health of Americans. Now, often that's been focused on actually reducing death rates. In the most recent decade of 2020, we did focus on a new thing, cardiovascular health, Life's Simple 7, to try to improve the overall cardiovascular health of the US population. And for this decade, we actually chose a shorter term goal. 2024, as it turns out, June 8th of 2024 will be the 100th anniversary of the founding of the American Heart Association right here in Chicago, where I'm sitting today. And so we wanted to have a shorter term goal that will be a ramp to our important end of our first century and the beginning of our second century. And we felt that nothing was more important than really addressing health equity as our 2024 impact goal. Not that we will solve all the problems by 2024, but we need to be well along our road to being champions for health equity. And so these were some of the guiding principles that we considered in pulling together our 2024 health impact goal. And I won't go into those in too much detail. But what we came up with was this statement you see here. Every person, no matter where they live in the world, every person deserves the opportunity for a full, healthy life. And as champions for health equity by 2024, we've pledged ourselves that we will advance cardiovascular health for all, including identifying and removing barriers to healthcare access and quality. All of this driving to, again, better health equity across the population. Important things, again, social determinants of health. The impact of structural racism affecting too many communities in this country and around the world. And of course, some special features around rural health as well, which I'm not going to talk about too much today. We pledge to drive advances in research and discovery. We want to raise awareness and empower people in communities to improve their cardiovascular and brain health. And we will continue our advocacy efforts at all levels to ensure access to healthcare for all, through Medicaid expansion, and through a number of other programs. And then once people get to the hospital, we need to make sure that they are receiving the best quality of care. We want to make sure we're raising all votes to reduce health disparities. So our metrics for this goal will be advancing cardiovascular health for all by improving health equity and tobacco-free living and high blood pressure control. We chose those two particular things because of this short timeline, but also not only will we have the biggest impact here in disparities, we will also have the impact on outcomes. Smoking and blood pressure are chronic risk factors for cardiovascular disease, but they are also triggers for acute cardiovascular events. So if we can tackle these things and reduce disparities, we'll have an outsized impact on health disparities in outcomes as well. And as I mentioned, focusing on better healthcare access for everyone and better healthcare quality when they engage with the health system. So one thing that I think we're particularly proud of is calling out the effect of structural racism as a fundamental driver of health disparities. In this paper, in the fall of 2020, you can see the sort of 5 pillars of our approach to address structural racism as an underlying cause of health disparities. And another paper I hope you'll take time to read because I think it's critically important, again, as we try to address the health problems in our marginalized, underrepresented, or under-resourced populations. And I won't read this in detail, but just to say, we really focus on not just identifying structural racism and the problems it causes, but actually trying to drive to a roadmap for solutions to those things. Just since the fall of 2021, when the board approved all of this, we've committed $230 million of resources of the American Heart Association in this short time frame to focus on structural racism and combating it. $100 million, which we've actually already spent in our research program, and we intend to spend a lot more. Community-led solutions, another $100 million, which we hope will catalyze further investment, not just from the HA, but beyond. And then a number of other strategies where we're really trying to focus on combating those effects of structural racism in our communities. So I just want to finish with a couple examples of our efforts to improve the cardiovascular health of South Asian people, again, using our pillars of science, advocacy, and community programs. So just as a few examples, I went to our research database, which anybody can access, and this is by far not comprehensive, but just in the last couple of years, these were grants that I found that we funded, again, often from young, that focus specifically on health issues in South Asian individuals, cardiovascular and brain health issues. So looking at genetic and clinical risk factors to enhance prediction of coronary artery disease in South Asians, a problem we identified in that 2018 scientific statement. Understanding endothelial function and glucose tolerance. Again, another one in cardiovascular risk that brings in perhaps some of those socioeconomic and social determinant issues. Ethnic differences in metabolism and atherosclerosis, again, trying to understand those underlying differences in cardiometabolism. And then some novel variants that have been associated with hypertrophic cardiomyopathy, and particularly in South Asian communities. and some other genetic studies. So a wide array, I think, of things here that demonstrates the portfolio that AHA is interested in. And again, I think specifically research in South Asian individuals is viewed as a priority because of the roadmap that was laid out in that 2018 scientific statement. We funded just recently a strategically focused research network. This is a $15 million investment on the science of enhancing diversity in clinical trials. We all know that too many populations are underrepresented in our big pharma and our big US government funded clinical trials. The issue here is that we want to not only understand how to improve a given trial, we want to understand the science of enhancing diversity of enrollment and retention in clinical trials so that it's reproducible from one trial to the next trial, not just fixing one trial's problems, but actually understanding the underlying issues that can enhance diversity in all trials going forward. And one of the centers in this network is focusing specifically, the UCLA Center, on Asian and South Asian populations and recruitment strategies that may be particularly helpful to get more individuals into these clinical trials so that we can learn more about the safety and efficacy of approaches to prevent cardiovascular disease. And then an example of our work in advocacy for cardiovascular health of South Asian Americans, many of you may have heard of this bill, HR 3771, which is called the South Asian Heart Health Awareness and Research Act of 2022. Not big enough, but at least a start. It authorizes $10 million to be spent on researching heart disease among South Asian Americans, and programs through the CDC that will also raise overall awareness within communities and start to address some of their perspectives on how we can improve cardiovascular health. So again, just a drop in the bucket of the federal budget, but an important start. And this bill has now passed the House with support from AHA advocacy. It is, like many things, sitting in the Senate. But if you want to help us, please sign up at you'rethecure.org, which is AHA's advocacy, grassroots advocacy website. And you can actually lend your voice here. You can find out who your representatives are. You can send them pre-populated letters and emails so that they will actually focus on this issue and other issues that are of interest to you. And we have, of course, much broader-based advocacy efforts that will hopefully raise all boats, working actually within India with the Public Health Foundation of India on both improving blood pressure control and CPR training. We are trying to enhance surveillance of cardiovascular disease and disaggregate this annoying sort of Asian Pacific Islander category that's used by NHANES and too many other of our surveys so that we really can understand the differences between people from different Asian heritages. I hope some of you have participated in our Go Red, Red Sorry events. They're really wonderful ways to promote cardiovascular health, particularly in women of South Asian heritage. And most recently, we've updated our cardiovascular health construct from the old Life Simple 7 to the new Life's Essential 8. The new factor is sleep health as a promoter of cardiovascular health. And I think completely endorse what Dr. Yusuf was saying about primary prevention, but we need to move even further upstream and focus on primordial prevention. The best way to prevent cardiovascular disease is actually to prevent the risk factors from happening in the first place. Because while we can treat hypertension, blood pressure, diabetes, once you've developed those things, and dyslipidemia, once you've developed those things, we can reduce your risk, but we can't restore the lowest risk of people who never develop those risk factors. And so primordial prevention, not letting the risk factors develop in the first place, is really the key to combating the cardiovascular disease epidemic. And again, many social determinants of health efforts. This is one of my favorite projects, actually, that we're keeping an eye on. The board of the American Heart Association for the Long Island region, led by several cardiologists and board members, has created the Long Island South Asian Project, which is focusing on empowering, as you see here, the community of South Asians on Long Island to create new opportunities through education and awareness, new connections, and new insights that are really driving towards improving health outcomes, and again, all about social determinants of health. So just to summarize, I think our organization, the American Heart Association, is truly invested in the health of South Asian communities and populations. We do use our main pillars of funding science, disseminating best practices through guidelines, following up with things like Get With The Guidelines, our care quality improvement programs, relentless advocacy at every level of government, and our broad-based community programs from schools to health centers and everything in between to try to promote health and prevent disease in all segments of the population. But we can't do this alone. We absolutely need your help in driving the science, in implementing best practices, in engaging with our community, improving awareness, and especially advocating for a healthier environment for all of us.